Pathological conditions of the ears, eyes, nose, and throat. Hearing loss. It may include the inability to hear specific pitch or the inability to detect any sound. Hearing loss affects approximately 1/3 of adults aged 61 to 70 and 80% of individuals over age 85. Approximately 10 to 15% of the population under age 60 has some hearing impairment. Deafness is defined as the inability to detect any sound. The most efficient and normal hearing pathway is through the air conduction. However, bone also conducts sound. In bone conduction, the vibrations of the skull are transmitted directly to the vestibulocochlear nerve or cranial nerve 8. Hearing loss can be divided into conductive hearing loss and sensorineural hearing loss. For conductive hearing loss, sound conduction pathways are blocked, and sound does not pass through the external and middle ear to reach the inner ear. This is also known as a mechanical dysfunction. The individual can hear if the sound is amplified enough. A buildup of impacted wax, injury, a foreign body, or infection in the external ear can cause conductive hearing loss. Otitis Media, a sinus infection, small or blocked eustachian tubes, and allergies can also be culprits of conductive hearing loss. Sensorineural hearing loss involves the inner ear. Most of the individuals who are born deaf have this type of hearing loss. The cause of this type of loss are typically idiopathic. Other identified causes include hereditary factors, meningitis, measles, scarlet fever, mumps, and encephalitis. Hearing loss can also be caused by the gradual nerve degeneration. Balance issues may occur with this type of hearing loss. Mixed hearing loss occurs when both conductive and sensorineural hearing loss occurs in the same ear. If hearing loss is suspected, refer the individual as soon as possible for proper diagnosis and treatment. Treatment and return to participation. The prognosis and return to sport are determined by the cause of the hearing deficit. Prevention of hearing loss is key. Preventing damage to the eardrum, extremely loud noises, blows to the ear, and excessive buildup of earwax can all damage the ears. Otitis externa. This is an inflammation or infection of the external auditory canal and tympanic membrane. Subgroups can include acute localized otitis externa or furunculosis, acute diffuse bacterial otitis externa, chronic otitis externa, eczematis otitis externa, fungal otitis externa, or otomyositis. This is very common for individuals participating in water sports. This is usually from a bacterial infection and is sometimes known as swimmer's ear. Common signs and symptoms include pain is the predominant symptom. In chronic cases, an athlete may complain of itching in the ear, and they may have the presence of pus coming out of the ear. Gentle pressure around the ear canal or pulling on the auricle or pinna may increase the pain. If left untreated, infection may spread to the middle ear. The management for otitis externa is the use of earplugs or the use of eardrops to keep the canal dry. Mild infections may be treated with rubbing alcohol or a mixture of alcohol and vinegar. Otitis media. This is the presence of fluid in the middle ear, accompanied by signs and symptoms of infection. The number of incidences dramatically decreases with age, as it occurs infrequently in adults but frequently in children. This often occurs simultaneously with an upper respiratory tract infection. This can be caused by a virus or even a bacteria. Dysfunction of the eustachian tubes is a factor in recurrence. Signs and symptoms typically include an earache, fever, a feeling of fullness in the ear, dizziness, tinnitus, headache, and diminished hearing. Children also frequently have a fever and will describe feeling sick. Referral and diagnosis for testing. Visualization of the tympanic membrane may be difficult. The tympanic membrane will appear to be bulging and will be more opaque than normal. There are 3 criteria necessary to confirm this diagnosis. There needs to be an acute onset, the presence of middle ear effusion, and signs or symptoms of middle ear inflammation. A positive Weber test will confirm conductive hearing loss in the affected ear. It is important that we refer the patient to a physician as soon as possible. Broad-spectrum antibiotics should be used to treat this condition. Air travel should be avoided until the middle ear has returned to normal appearance and function to decrease the risk of a ruptured tympanic membrane. Ruptured tympanic membrane. This may occur when there is a sudden change of air pressure caused by blunt trauma or an infection that inhibits the ability to regulate the inner ear pressure. Infection is the principal cause. Increasing pressure in the middle ear often causes extreme pain before the rupture happens. A rupture can also happen as the result of sticking a sharp object, even a cotton swab, in the ear. Common signs and symptoms may include audible whistling sounds and decreased hearing, purulent fluid or bleeding leaking from the ear. This condition, however, may be painless. Hearing loss is often more severe if the ocular chain is disrupted or inner ear is damaged. Vertigo may be present with inner ear injury as well. The diagnostic test is typically not needed above an otoscope examination. The patient's history and physical examination are often enough to make a diagnosis. Audiometry is performed to determine the amount of hearing loss. Treatment and return to participation. The tympanic membrane tends to heal itself. It can take 3 to 6 months for the membrane to heal. During healing, remember to protect the ear from water and debris. Large or complicated ruptures should be referred to an otolaryngologist and may involve a graft or surgical paper, fat, muscle, or other material to correct. Auricular hematoma is also known as cauliflower ear. The most common mechanism is from repetitive blunt trauma that pulls the cartilage away from the perichondrium. If this condition is left untreated, a hematoma forms, and eventually the hematoma can lead to fibrosis. Lastly, there is necrosis of the auricular cartilage that occurs. For treatment and management, ice can help reduce pain and swelling in the injured area. If the hematoma persists, it must be aspirated by a physician. Following the aspiration, a pressure bandage should be applied to prevent the hematoma from reforming. Protective headgear is best for the prevention of this in sports. Impacted cerumen, or impacted earwax. The signs and symptoms most commonly are impaired hearing. The management is irrigation of the ear canal with warm water. It is important that cotton tip applicators should not be used to clean ears. This may require further intervention by a physician, which we'll see on the next slide.
Hi everybody, this is Rhys Barber from Audiology Associates, and we've got another earwax extraction video for you today. As you can see, we have some very deep-seated earwax which is stuck almost on the eardrum itself. So quite a difficult one to do. We're just going to start with a standard Zollner tube, but you can see that there's not enough room in this ear canal to fit a standard Zollner tube and the endoscope. So we've had to switch to a much smaller fine end, so it's going to take a lot longer to remove this because we're going to take little tiny pieces away at a time. So you can see there's a little bit of wetness in there. That's where the olive oil's gone in just to try and soften some of this wax a little bit. So very gently trying to maneuver some of these smaller pieces of earwax away. Just working our way around. Now this is one solid piece of wax, this one, so I'm trying to break little bits off, and I've got to be really gentle because it's actually pushing up against the eardrum. So you can see the whole thing moving. If you look to the right hand side, it's just blocked the view there a little bit, but you can see the whole section moving there. There we are, just pulling away slightly. See it all just, there you go, just taking a little piece away. The difficulty with using a fine end, normally with a like a larger piece like this, you'd use the standard Zollner tube, but we just don't have enough room in this ear canal. It's so narrow and so small that we're having to use the fine end, and it's just a case of breaking these little tiny little pieces of wax away. So I'm going to go in, take it away, because the wax is quite hard as well. It's not getting sucked inside the tube itself, it's just sitting on the outer section of the tube, so it just blocks the RC, it just blocks the suction up straight away. So I'm having to constantly take a piece away, go back in, take a piece away. Here we are, just getting a grip on the next section. Here we are, all the time just trying to move it sort of sideways. You can see there's still a great deal of wax in here. Now when you look to the right, you'll see a lighter beige colour to the right of where the suction is at the moment. That looks like an old piece of dead skin, and I think we can see the bottom section of it, the white section just below the suction tube there. So I think it's actually sitting on a piece of dead skin which is sitting just in front of the eardrum itself. But just trying to find any kind of movement or any loose section of wax there to work on. You know, just see it starting to move. There, I'll take the top section away there a little bit. Still trying to be very gentle with this. Trying to tease this away as best we can. Yeah, you see that that's one solid plate there at the top, so I find it difficult to try and find any way that we can get a good grip on this wax. This is why it was such a difficult extraction, because you're working in a really confined space, so very small limited movements in here, and you're working with the fine end, which makes it a lot harder because it blocks up so easily with any little bits of wax on, and because it's such a hard piece of wax, it's not getting sucked into the machine at all. It's just blocking the suction end constantly. So quite a laborious task getting this one out. Now we've just found there's a little, there you go, there's a little bit of flat of dead skin. Now this looks like it's all connected to that piece of wax. So when we start pulling on it, you can see it's quite difficult to maneuver, but you can see the whole section of wax is just starting to move. There, it's coming away from the eardrum. So we're going to work on this bit of skin, but as it is, it's breaking away. Now, I know you guys have seen me use crocodile forceps to go in and remove this. The difficulty here is the crocodile forceps wouldn't fit. The ear canal itself would accommodate it, but I couldn't accommodate that and the endoscope at the same time. So we're having to just very slowly work our way along this, just trying to get a grip on the skin. But when you're putting the suction in, obviously the skin gets pulled into the suction, so sometimes as you're trying to move it out of the way, the suction pulls it back into place. It's just breaking little pieces away. There we are. Just trying to maneuver this wax, but it's so difficult because we've got to be conscious of the wax and trying to maneuver the skin into the right position to get a good grip on it with the suction. It's proving a little bit difficult. There we are, just starting to turn it. Okay, just breaking, there you go, you can see a piece of this old skin coming away. There we are, and then just getting the next section coming away now. There we go, just trying to get a grip on the skin or the wax. There we are, now we're starting to get some movement to the wax. You can just see it starting to move. If there's a little bit of misting on the camera, it's because this lady used quite a bit of olive oil in here, so it's you do sometimes hit a little bit of olive oil as you're going through little hairs as you're going into the ear canal. Couldn't get out with the standard, with the fine end, so just switch to the standard size on, and now just remove it, the outer section. There we go. And the next section, just going in with the standards on the tube again. There we go, getting a grip on it. You see a couple of little hairs from the head there, just on the outer part of the ear canal. And just looking in now, we can see we've got some skin debris left in there. That needs to come away because that's still resting against the eardrum. So this is the fine end again. Just looking to try and get a grip. Obviously you've got to be very careful, just hovering above the ear canal wall there, because we know it's very sensitive. Just going in for the next section now. There we are, we've got a long kind of, there we are, there's that skin, the remainder of it. There we go. See that long strip there. We go back in, there's a tiny little bit of the wax there, so we'll remove that. You can see a little bit of redness, a little red dot on the eardrum as well. It's just pulled a hair in from the outside there as well at the same time. That's still attached to the head, so it will come back out with the suction. There you go. Okay, now you can see there's some fine hairs in here. Now I get asked this question a lot, why don't we remove these fine hairs? Look what happens when you put the suction on them. That's all they do, is just flap around at the end of the suction, but they don't actually go anywhere. Okay, you might get the odd one that gets sucked in, but there's still a little bit there. You can see the eardrum there. So these will get washed away with the next bath or shower. This is what we removed. You can see how small some of these pieces are that we were working on, but yeah, really tough extraction today. But thank you very much for sitting through it, guys, and as always, like, subscribe, share, and take care.
Allergic rhinitis is an immunoglobulin E-mediated response to nasally inhaled allergens that causes sneezing, rhinorrhea, nasal pruritus, and congestion. Non-allergic rhinitis results from nasal inflammation due to infection, vasomotor, occupational, hormonal, drug-induced, or gustatory processes. This produces excessive mucus. 10 to 20% of the U.S. population suffers from seasonal allergic rhinitis triggered by pollens, ragweed, or even grasses. Signs and symptoms may include clear nasal discharge, sneezing, nasal congestion, cough, and a sensation of plugged ears. Itchy or watery eyes may also develop, and post-nasal drip may irritate the back of the throat. Allergic rhinitis can be associated with many comorbid conditions, including asthma, atopic dermatitis, and nasal polyps. A medical history can often be useful in identifying this condition. Referral for patients who have had symptoms that persist more than 7 days is recommended. Allergy testing may also be required. Treatment may include allergen avoidance or pharmacotherapy. Over-the-counter antihistamines generally control symptoms and have fewer side effects than prescription medications. Intranasal corticosteroids are now available over the counter as well. Targeted symptom control with immunotherapy should be considered for individuals who have moderate to severe symptoms. Non-allergic rhinitis may have a yellow or brown discharge with a fever, which indicates a bacterial infection. The use of air conditioning, maintaining indoor humidity below 50%, and air filters may also be helpful to this condition. Sinusitis, inflammation of the mucous membrane lining of the nasal cavity, or one or more of the parasinuses, is required for this condition. This may be acute, subacute, recurrent, or even chronic. Common signs and symptoms include previous upper respiratory tract infection, with post-nasal drip lasting for 7 to 10 days. Purulent nasal drainage or discharge, facial tightness, nasal obstruction, and headache are also common. Individuals may complain of point tenderness over the infected sinus and a toothache with maxillary sinus involvement. A cough may be present, worsening at night. Patients should be referred to a physician, and pharmacological treatment can be started. The diagnosis is typically made through the history and examination of the individual. Transillumination of the sinuses will confirm a blockage. Saline nose spray may help clear the nasal crusts and thick mucus. Topical decongestion should only be used on a short-term basis only. Most cases are viral in nature and will resolve within 2 weeks without pharmacological treatment. Frequent hand washing is the best line of defense to reduce the chance of infection. A deviated septum. This typically occurs as a result of trauma, often a blow to the side of the nose, and it may present with epitaxis or nosebleed, and is often associated with nasal fracture. It's often discovered well after the initial trauma has healed. This may present with only a minor deformity or complaints of chronic nasal obstruction. The septum is the partition between the right and left side of the nose. This may be congenital and asymptomatic. If the septum is displaced, it may lead to breathing difficulty. Common signs and symptoms for a deviated septum include differences in airflow between the two sides. Inspection with an otoscope will allow us to visually see this. A septal hematoma may be visible with an otoscope. For management, we should refer to a physician. Surgery is typically required to drain the septal hematoma or repair the septum. Epitaxis. This is commonly known as a nosebleed. This is a common occurrence among athletes and is typically associated with trauma to the nose, but it may occur without trauma. There are two types of nosebleeds, anterior bleeds and posterior bleeds. More than 90% of nosebleeds occur anteriorly, where the Kieselbach's plexus forms on the septum. A posterior bleed is usually more profuse and often has an arterial origin. The management for epitaxis: apply mild pressure at the nasal bone. Apply ice and tilt the head slightly forward. A nasal plug may be used, and if bleeding persists longer than 5 minutes, refer to a physician. Instruct the individual not to blow their nose. Also, don't tilt the head back, as we can choke on the blood as it goes down the throat. The idea is to let the blood run out of the nose unobstructed. Red flags for nasal conditions: if there is a unilateral blockage following trauma, visualization of polyps, visualization of a deformity, loss of smell, or unexplained epitaxis should all be referred immediately. If direct pressure is not enough to treat an anterior bleed, gauze moistened with phenylphrine, also known as neosynephrine or pseudoephedrine or Afrin, may be placed in the affected nostril to help promote vasoconstriction. For recurrent nosebleeds, conservative treatment, including increased humidity, using saline nose drops, and applying antibiotic ointment to the nose may be beneficial. Athletes susceptible to nosebleeds may need to wear facial protection to limit trauma during athletic participation.
426 kilos. Come on!
Pharyngitis and tonsillitis. Pharyngitis is an inflammation of the pharynx and commonly known as a sore throat. Tonsillitis is inflammation of the tonsils. Both may be caused by bacteria or a viral infection. Pharyngitis is initially viral in most cases, but may be followed by a bacterial infection. Tonsillitis is most commonly caused by beta-hemolytic streptococcus. Signs and symptoms include sore throat, pain with swallowing, hoarseness, and chills or fever. Viral and bacterial pharyngitis can occur. If it is viral, it is usually accompanied by rhinorrhea, conjunctivitis, and a cough. Bacterial infections will commonly present with a higher fever and signs of infection. Fever and swollen neck lymph nodes are common. Patients with symptoms for more than 5 days should be referred to a physician. A throat culture is often conducted to determine the cause of the condition. A complete blood count may also be taken to examine leukocyte counts, with high counts supporting the bacterial infection. A 10-day course of antibiotics are typically required to treat this condition. Drinking plenty of fluids and saltwater gargles can help the patient. Full recovery should typically occur in 7 to 14 days. Rheumatic fever can occur from untreated streptococcal infections. Frequent hand washing can help prevent disease transmission.
Laryngitis. This may be caused by direct trauma to the throat, gastroesophageal reflux disease, also known as GERD, allergies, cigarette smoke, or excessive use of the voice. This is common in an athletic population and has also been termed cheerleaders' nodules. Hoarse or weak voice is common, and in some cases the individual cannot speak. The individual has a constant urge to clear their throat and may have a tickle sensation. Fever, dysphagia, malaise, and throat pain may occur. Edema of the larynx may cause dyspnea. The patient should be referred if symptoms do not resolve in 5 to 7 days. An indirect laryngoscopy may diagnose this condition. Cultures and biopsies may determine if other conditions other than viral infection and irritation are present. Voice rest and increased humidification may help to relieve symptoms. Patients should be instructed to avoid alcohol and caffeine due to their diuretic effects.
Oral mucosal lesions. These may be caused by local trauma, infectious disease, autoimmune disorders, neoplastic disease, and toxic reactions. Identification of atraumatic oral lesions is important and may allow for early recognition and referral for oral cancers or infectious diseases. Oral lesions are often the first clinical evidence of HIV infections and AIDS. These lesions are often white or pigmented. White lesions that can be easily removed are more likely Candidiasis. Brown or black pigmented macules on the oral mucosa may be caused by something as benign as localized melanin production, or may be a malignant melanoma, so it's important to have these checked out. Oral candidiasis. This is caused by a yeast-like fungus called Candidia albicans. This is also called thrush in infants. This is presented as a white, cheesy, curd-like patch on the tongue and buccal mucosa. This is most common in newborns, but can be seen in older adults as well. This may occur after the use of antibiotics. Oral candidiasis can be scraped from the tongue with a tongue depressor and typically bleeds easily. Oral rinses of nystatin or oral antifungal medication can be used for 2 weeks or until symptoms resolve. Oral cancers. These often involve the tongue, lips, and gums and account for 3% of all cancers in men and 2% of the cancers in women. This occurs more often in African Americans than Caucasians. Predisposing risk factors include any tobacco use, excessive alcohol use, poor oral hygiene, being greater than 40 years in age, and a family history of oral cancer. Men have nearly double the risk of women for developing oral cancer. Red flags for early signs of lip and oral cancer include a sore in the mouth that does not heal in 2 to 3 weeks, any sores that are painful or bleed easily, any unusual lumps in the mouth, numbness or pain in the mouth or throat, persistent red or white patches on the oral mucosa, a change in the voice not associated with a cold or allergies, and difficulty chewing or swallowing. Dental disease, also known as gingivitis. Gingivitis is an inflammatory condition of the gums caused by bacteria. Bacteria present in food and not removed because of inadequate brushing and flossing will produce plaque deposits leading to gingivitis. Common signs and symptoms include tender, swollen gums, bleeding with brushing, and changes in color in the gums. Plaques are soft white forms of salivary salts that are trapped protein and bacteria. We can also see recessed gums, bad breath, and tooth pain. The management is to obtain professional cleaning from a dentist. If gingivitis is really bad, antibiotics may be prescribed, or surgery may even be necessary. Prevention of periodontal disease should include frequent brushing and flossing, as well as an antibacterial mouth rinse. Regular dental visits allow for periodontal disease to be identified and detected early. Periodontitis is another dental disease. This is advanced gingivitis, and it may require treatment with antibiotics, tooth scaling, and removal of plaque below the gum line. Advanced periodontitis results in loosening of the teeth, and athletes participating in contact sports must be cautious and use appropriate mouth guards. Another dental disease is caries. Tooth decay caused by accumulated bacteria on the enamel surface, which forms plaques, is known as caries. Decay starts at the enamel and may extend into the dentin and even the pulp of the tooth. Caries can be classified as pit and fissure, smooth surface, cemental, or recurrent. Decay will initially look like a white or chalky substances on the tooth, and will later turn black or brown. Dental decay is often asymptomatic in its early stages. In advanced stages, the teeth may become sensitive to cold or hot. Red, swollen gums may be present. If an abscess forms around the tooth, it will likely be painful. Patients should be referred to a dentist for proper treatment. Depending upon the severity of the decay, cavities can be repaired with fillings or a crown. If the pulp of the tooth is involved, then a root canal may be needed, or the tooth may need to be extracted. Loose or displaced teeth. We have displaced, intruded, extruded, and avulsed teeth. The management for a loose or displaced tooth depends upon what is happening with the tooth. If the tooth is moved laterally or outwardly, place the tooth back in its original position, but do not force it. If it is intruded, the tooth should be left alone and referred to a dentist as soon as possible. For an avulsed tooth, we try to stick it back in the socket if it will stay. Have the individual bite down on a piece of gauze and refer to a dentist ASAP. If the tooth won't stay in place or you're afraid that they may swallow it, take the tooth out and place it in a tooth saver or a glass of milk if you have one available. Be sure to avoid touching any part of the root of the tooth. If we touch the root, it will likely die and the tooth will not be able to be saved. So it's important that we handle teeth correctly. For a fractured tooth, common signs and symptoms include fracture through the enamel, may cause no symptoms and can be smoothed by a dentist. A fracture that extends into the dentin of the tooth may cause pain and increased sensitivity due to heat and cold. The management for a fractured tooth is the referral to a dentist. Often a dentist will need to make a temporary tooth and will later replace that tooth with a crown. If the pulp of a tooth is exposed, a root canal may be required prior to placement of the crown. Here's a visual representation of different types of tooth fractures. This can be helpful to understanding the severity and the treatment for these tooth fractures.